Welcome to the Future of Dermatology podcast. I'm Dr. Faranak Kamangar. What you're about to hear is a standout session from this year's SF Derm conference in Napa, where leading voices in our field gathered to explore what's next for dermatology.
These are truncated replays from our original recorded sessions. Join us in September of 2026 to get the full impact of the SF Derm experience.
Acne is the most common dermatologic problem that we see as dermatologists. It affects 10% of the world's population, and very fitting that we discuss this today. So we all know that there are systemic treatments for acne. They all work to a certain extent. We've got isotretinoin and spironolactone antibiotics, but they do have several downsides. One, they do take several months to work. They're often teratogenic. There are concerns of increased antibiotic resistance with prolonged use of antibiotics, systemic antibiotics. They're poorly tolerated by some patients. We all have the patient taking spironolactone complaining of lightheadedness, etc., period irregularities, unwanted, and in some patients, unacceptable risk profile. So a classic example would be a female to male transgender patient who's already undergoing testosterone therapy and not wanting the effects of testosterone or androgen blockade that you'd see with spironolactone. And then, of course, we all have the typical eye pledge monitoring annoyances. This is one area where I was really hoping that Elon Musk would really help us out as dermatologists. But we all know how that's played out.
Chainsaw.
Exactly. Chainsaw, break down eye pledge. It didn't quite work out that way. Okay, so lasers and energy devices are attractive treatments for managing acne vulgaris because there are multiple active chromophores in the skin that are involved in the acne pathogenesis pathway. Over here, we can see that, of course, the first step in acne pathogenesis is there's follicular hyperkeratosis, there's follicular plugging, there is an overgrowth and overproduction, overgrowth of sebocytes, but also overproduction of sebum in the skin, and that leads to an overproliferation of bacteria, particularly the Propionibacter species, resulting in inflammation. Once that inflammation goes pretty down to the base of the follicle, then there's heavy inflammation, which often leads to scarring in the dermis. And so, what are some examples of energy-based devices that we can use in management of acne? We all know about photodynamic therapy. The target there is, again, the Propionibacter species of bacteria. Those are they produce porphyrins. Porphyrins absorb that Surrey band that we remember from residency. So using that laser or that energy-based device, we can target acne, decrease inflammation. Dr. Kamangar is going to talk about AvaClear, a similar device, AvaClear. These again target sebum. They cause sebocyte apoptosis, and again there's a decrease in inflammation. And then what I'll talk about today is the use of broadband lights or intense pulse light. Here we have a number of different, so again, broad-based light, and you could filter based on the specific chromophore in the skin that you were trying to target. So there's a 420 nanometer target. Again, that's P. acnes. You could use that to decrease inflammation in moderate and severe acne. There are targets for the vasculature, so yellow light and also red light, causing photocoagulation of the vasculature, decrease in inflammation, decrease in post-inflammatory erythema. And then again, this near infrared, but also visible light that causes bulk heating effects in the dermis, leading to collagen breakdown, but then also collagen production. We also see, theoretically, there is absorption of both collagen and water at these wavelengths. So there is a theoretical increased collagen production with those lasers as well. Okay, this just shows the absorption spectra of the multiple chromophores in the skin. Over here in the green, you have water. So again, at those near infrared wavelengths, you're getting that bulk tissue heating effect and increased collagen production. Over here in the red, this is where your yellow light really works, also red light as well. Again, targeting the vasculature in the skin. And then this talks about fat, but sebum is also up here, about 1726. And again, this is just showing in blue the bulk heating effect that you would see once you stimulate water in the skin. Okay, what are some downsides of some of these technologies? Number one, pain. So AvaClear Again, the first sebasite targeting laser device, not quite as popular because patients just complain this is a very painful procedure. Next would be PDT. Use of a photosensitizer is often complicated. Getting aminolevulinic acid, expensive, complicated. And then also with this particular treatment, there's extensive downtime, lots of swelling, lots of erythema, which makes it really hard for an acne patient to be convinced to do this. With IPL or broadband light sources, one must consider the risk of PIH, especially in patients with higher Fitzpatrick skin types. And then another really important thing, we don't have any standard protocols for how to use these lasers. How efficacious are they? How efficacious are they? And are there any long-term efficacy studies? Meaning, like after you're done with the series of treatments, how often do you need maintenance treatments? And then, of course, out-of-pocket costs, which is always a primary concern to a lot of our patients, especially to those of us doing medical dermatology. Okay, so how do I select a patient for laser therapy? So these are usually patients that cannot tolerate systemic medications or don't wish to undergo systemic medications. So number one, we would be a pregnant patient, where of course we're worried about teratogenic effects of a lot of the systemic medications that we have. We have patients that have this need for holistic treatments. They don't want any antibiotics. They don't want any systemic medications. They're like, can you just give me topicals? But when the topicals are not quite working, what else can we offer? We have patients that are unable to tolerate medications due to side effects, as we mentioned. Patients that require, they're okay with starting systemic medications, but they have either like a pressing social event and they just want rapid reduction in the number of acne lesions and also the amount of inflammation that they have. And of course, we have the teenagers who say, oh, I use my meds, and they're, of course, they're not getting any better and they want to have additional options. And then patients who don't really want to do Accutane or iPledge. Okay, so this is what I do. I call it my acne laser series. It's a protocol that uses visible and near infrared lights. I do it in a series of 2 or 3 steps for patients. And this is just for patients with moderate to severe inflammatory acne. I do multiple passes with specific wavelengths, so specific filters like narrowband filters, performed on the same day, and I perform it to areas of acne, active acne, as well as areas of early scarring. So patients with red, like recent scars, so red or purple, either atrophic or hypertrophic scars. I do a series of 6 treatments spaced about 1 to 2 weeks apart. Recently, I just do space them 1 week apart, and I do a series of 6. So these are some of the results. So this is week 0. This is a patient with inflammatory acne, moderate inflammatory acne. There's some scarring here, mostly hypertrophic, but also atrophic. She also has a background of erythematous telangiectatic rosacea. This is her at week 3. This is her at week 7. So rapid improvement, not just in the active lesions, the number of lesions, they're no longer active, but they're also in the amount of erythema associated with those lesions. Okay, so this is my protocol. Step 1, I usually don't numb these patients, which sounds mean. So no topicals. I use first step would be, so this is using either just an IPL device or a broadband light device. Really, any specific manufacturer, it doesn't really matter as long as you have a way to filter out these specific wavelengths. So the first step is I use a narrowband blue light filter, so between 420 and 480 nanometers. And I use a broad light guide. So I treat the entire area of active acne, not just the individual lesion. So where they have active acne and also where they're acne prone. So typically it's forehead, cheeks, chin, sometimes neck, but then also in some male patients, chest and back. And the mechanism here is, again, the blue light is reacting with the porphyrids that are naturally present in these Propionibacter species, and it causes a photoreaction that kills these bacteria. I do this again, multiple passes, very low fluence, done once a week. Next step, I do either yellow light or red light. Red light, usually my higher Fitzpatrick skin types, like 3 and 4. Yellow light in my Fitz 1 and 2. And here I do just on active inflammatory acne lesions or where they have those recent red or purple scars. I do sequential passes to each individual area, not stacked. I always apply cooling. And again, the mechanism here is this photocoagulation of the vasculature, and there's rapid improvements in both active and post-inflammatory erythema, and also areas of depressed scarring. Step 3 is that bulk heating effect. I use near infrared filters. So on one device I have, it's called Skin Tight. And it basically just heats up the skin so rapid passes all over the skin. wherever they have active acne and also areas of scarring. And again, the effects there that there's neocollagenesis. I use this protocol in pretty much all Fitzpatrick skin types with a couple of variations for my higher Fitzpatrick skin types. I usually don't do topical anesthetic for my lower Fitzpatrick, but then I'll talk about my higher Fitzpatrick. And really, you could use any broadband light device. Hmm. Okay, so what are the variations I use for my higher Fitzpatrick skin types? So skin types 5 and 6. For step one, I still use the blue light filter, but I use a device that breaks down that particular fluence into multiple pulses. So, for example, instead of giving one pulse of 4 joules per centimeter, I would break down that fluence into a series of subpulses that total 4 joules per centimeter. So breaking down the amount of energy and delivering subpulses, I still do the same number of passes, but the overall effect is that there is less heat applied to the skin and there's lower chance of PIH in these patients. I skip the red light step in these patients. They don't really have a lot of erythema. The concern there's usually hyperpigmentation, so I skip that and I go straight to the visible and IR spectrum. So using an 800 nanometer filter, and there I apply to the active areas and also areas of hypertrophic scars. And the result there is really, with cooling, the goal there is to create this increased collagen production. And then an optional step where they have active scarring is I do just once a month or just sometimes just once. I use a non-ablative fractional laser, something with erbium glass, and just to focalize, localize areas of scarring. This last step is pretty painful, so in these patients, I apply topical anesthetic. Okay, so this is that same patient. I already showed that's week 0, the week 3, week 7. So usually what I first see is just rapid improvements in the amount of erythema, rapid improvements in the amount of rapid decrease in the number of active lesions. So usually they have fewer lesions that are red, and there's overall improvement in just even the surrounding erythema that she has as part of her rosacea. Same patient, and this is just showing again improvements in the area of rosacea on the cheeks. Another patient. This patient was actually she was on topical, the tretinoin, topical clindamycin, topical Winlevi. She did not want to take spironolactone, but she'd come in at about once a month asking for injections to inflammatory lesions like cystic acne. And so we just started treating all of these active areas. So this is her at week 0, this is her at week 6. So every week she just had gradual improvements, both again of the number of active lesions on the chin, but also the amount of um, erythema and induration. This is another patient, I said this fun patient. She was traveling with a circus and didn't want to take any meds, very holistic, would come in for weekly acne treatments, but was only in town for about 6 weeks. So we got her Claire, but then at month 7, she was like, hey, what else can I do for my acne? Interesting thing I've noted is this works again more for inflammatory and moderate to severe acne. I don't find that it works that great for comedonal acne. So here, month 7, her chin is clear, mostly clear, but she has all of that. So just an observation. Another patient, this patient's also on topicals, um, also topical Winlevi. She had mostly her residual acne was mostly on the chin and neck. Again, this is somebody who would actually do beautifully with spironolactone, but she didn't want it. And so this is her at week 12. So week 6, her skin was clear. By week 12, she started to have, you can probably see couple faint lesions, recurrent. And she's like, what else can I do? And that's usually for me another introduction to spironolactone. Okay, well, we've done this. Your skin is better. You're going to have a lasting result with spironolactone. How about we try it? And she actually went on it. So um, uh, I find that with some of these patients, giving them what they want initially gets them to buy into your recommendations for, again, either more effective therapy or just lasting efficacy. Same patient here, again, just showing the neck lesions and also the chin. Also improvement in her rosacea on her cheeks there compared to there. Okay, in contrast, so these patients actually do fine on Accutane, but the thing I find with Accutane is there's this persistent erythema even at month 6 during treatment. So I find that the patients I treat with lasers just have a very rapid resolution or improvement in their erythema. Okay, so benefits to the patients, no post-procedural pain or downtime. The treatment sometimes is a little uncomfortable, but no one cries and we ice afterwards. Everyone's happy. I start seeing improvements usually after a week. These patients are actually usually very happy and very motivated to return. marked improvements in the number of active acne lesions, but also scarring. I actually found a paper that talked about this, and he uses a particular, very similar to what I do, but he uses a particular device. And in his case series, he found that most patients, so 80% of his patients, had either marked improvement, so 75% improvement, to complete clearing after about 6 weeks. In his study, he found that the results lasted about 6 months. Um, and I haven't done this on enough patients to know if it lasts 6 months for it in my practice. And then he maintained results with repeat treatments every 1 to 3 months. And in my case, I combined with topical therapy. His case, he was doing just using this as monotherapy. Okay, so benefits to my practice or to your practice. You get happy patients that really buy into your treatment recommendations, even if they're reluctant to try the oral medications initially. A lot of times they're okay transitioning after a series of treatments. And then for practices that are, a little worried about getting into cosmetics, this is a good way to merge, again, a medical practice with some cosmetics. Most people have an IPL. You can use an IPL device. It's pretty straightforward. And then again, for patients with more extensive or older scars after this series of treatments, then we move into treating their much more extensive scars. So like a patient like this. This patient has, I didn't treat his acne, so I saw him when his acne was already under control, but extensive scarring, mostly atrophic areas, rolling scars, some hypertrophic areas there. And patients like these, I do a pretty robust and pretty aggressive, this is what I talked about last year, but pretty aggressive regimen of ablative laser resurfacing, but also with full face subcision under tumescent anesthesia.
Thank you so much, Dr. Carlson. That was a wonderful talk. And what we're really trying to do is change the paradigm of acne treatment because we know that topicals, they'll work to some extent, but they're never like quite the answer, especially for moderate to severe, even sometimes mild patients. And then we have all these other therapies and they're kind of okay. I mean, I think we all kind of feel that way about our acne therapies. The reason I'm talking about the AvaClear laser is when you talk about acne laser, it sounds like one thing, but they're really not. Like what Dr. Carlson talked about, there are so many different wavelengths of lasers and they do different things, and it's kind of important to understand them. And also, the AvaClear is so new and so novel. The technology has been around for a long time, but kind of being out in the world, it's a novel type of treatment. So it's important to start to understand where to use the different lasers and which patients they fit in. For me, I really love the idea of curing acne. And in the past, that pretty much meant isotretinoin because nothing else really is sebostatic or cause sebocyte apoptosis. You can't really touch the sebaceous gland without anything other than isotretinoin. Before lasers, of course. Even our topical retinoids, when it comes to sebaceous biology, they're not doing a whole lot. So really, to get rid of acne long term, you need to get those sebaceous glands to go down. Isotretinoin, to me, I like it a lot, but not everybody wants to do it, and not everybody can do it. So there's a lot of limitations with it. This room knows that really well. What's unique about the AvaClear is that the 1726 nanometer, and we'll get into the actual slides, but I just wanted to kind of make the point of differentiation between the lasers. The 1726 nanometer with selective photothermolysis kills off your sebaceous gland. So that's only something isotretinoin has been able to do before, and not a little bit of isotretinoin. You need to be on it for a really long time. Like when you're getting to 89, 80 to 90 mgs per kg, you're kind of getting into sebostatic land. Whereas, you might have killed off some sebaceous glands, but really if you stop too soon, they might look clear, but if it's just sebostatic, it's going to brought the sebum production down, but not killed off the sebaceous gland, but acne is going to come back in some time. So you need a lot of Accutane to actually kill off enough sebaceous gland to get long-term cure. And like we talked about last night with Dr. Carlson, I think you prefer to even sometimes go to 200 mg per kg just right off the bat, rather than even just kind of deciding later to do it. And I still kind of go for that 120 to 150 mgs. And so I'll get into the actual slides now, but I just wanted to differentiate where these lasers are different and where the mechanisms are. And I love what Dr. Carlson talked about with the redness, because if you haven't gotten rid of a patient's redness, the journey is not done. Like a lot of you have probably had the moment where your MA comes and tells you your Accutane patient is waiting, and they said they're not any better, and you walk in and all their acne is gone. You're like, there's no acne, but there's redness. So to them, it's not better. So getting the redness is also very important. Let's get into the slides. Of course, we know what we usually treat with, so I won't go over our usual treatments too much. This again is kind of a paradigm, and Dr. Carlson went over this. This was an interesting survey that the Cutera group did. And one thing they found out was that 8 in 10 people were actually interested in the survey to learn about lasers. And I found this to be true too. When I didn't really have like an AvaClear type of laser, I didn't talk about laser and I didn't really bring it up. And that happens when you have the technology, then you start talking about it. But when I started just bringing it up casually, is like, okay, this is also another option. You do really see that a high percentage are like, wait, what's that? I don't have to do Accutane. What's that other thing to tell me about? So, and I realized, not having mentioned it previously was kind of a missed opportunity for some patients just to be educated about what's out there, whether they pick it or not. So again, we know what causes acne, and Dr. Carlson went over this. So I won't go over it in depth, but just to talk really that the sebocyte biology is the key to acne. And you can decrease the inflammation, you can do all these other things, but unless you can block the hormonal routes, but unless you've done something to the sebaceous gland, you're not going to get long-term cure. You're going to have to kind of stay on everything you're doing. So this is really the money shot really of all the slides here. The 1726 nanometer, it selectively targets the sebaceous gland, which is very unique. This technology has been around for a long time and studied, but it was uncomfortable enough that you really couldn't use it. Whereas what they've done now is make lasers that are able to cool the skin enough so that the laser beam can actually selectively go to the sebaceous gland and not touch anything else. And it's safe in all skin types. Another kind of money shot because we like Derm Path. This is a healthy sebaceous gland, and then this is a sebaceous gland after you zap it with AvaClear. I mean, you'd have to use a lot of isotretinoin to get to that point, and you can now do it with like zaps with a laser. So that's very unique. And isotretinoin is doing this all over the body. This is very localized to where you're having the problem, whether that's the face for most, and then possibly back as well. And I believe this must be yes, I think this is histology data that was presented just recently at the ASLAMs, actually, and I found it to be really interesting, so I asked if we could present it, so that's why it's kind of inserted in there. But this was a really cool trial. This was I believe it was, patients undergoing facelifts, so they were gonna cut off some skin anyway. So what they did is they just the area they were gonna remove, zapped it at higher and higher doses just to see how high you can go. Because really what you want is that sebaceous gland apoptosis, how high you can go without hurting the skin. And so this is so in kind of just to put it in perspective, when we talk about this was 5 subjects that they did this with in the pre-auricular area a few days before they had their facelift. When we treat with AvaClear in our clinic, you might go somewhere from, let's say, 18, 19, maybe 20 kind of fluents, but usually about 19. And so they went from 20.5 up to 30, which I don't think anyone's really doing, but it's really good to see how much could you push this, because when a novel therapy comes out, then it comes down to once we're just really excited, the second step is, really fine tuning and see what we can do. The amazing thing is, which is probably the next couple of slides, is everyone did well and it didn't actually burn the skin. I know superficially, which is the important thing that you want to see, and you want to look for epidermal damage. That was really the main question. How hard could we zap the sebaceous glands with and leave the epidermis intact? And these were the histology studies. So at the top, it says the fluence. So they first tried it at 20.5, and that looked pretty good. The epidermis is left untouched. So that's really what you want to see. And then you're seeing some sebaceous gland destruction at the depths that you want to see it. So those are the metrics that they were looking for. And then also no inflammation. This means just selective photothermolysis. You're going for what you want. You're going in, you're taking it out, and then you're leaving, not leaving a site. So and this is at 25 joules, similar sebocyte death with fibrinoid necrosis, no inflammation, epidermis normal, no epidermal injury. This is kind of what you want to do. 28 joules, same thing, no epidermal injury. 30 joules, which I was like, at some point, they're going to get to a point where they start burning the skin. But again, no epidermal injury. So just proving really that it's very, very selective. And these are like really select small studies, but it's interesting to see how much can we push these therapies. Right now, AvaClear's 3 treatments. You get one once a month and you're done with it. And then we usually tell patients, though, you can continue to get clear up to about a year, just so that they have that in their mind that it's not like treatment number 3 and everything's fully gone. But I think we're going to be pushing these things even further and higher and getting, patients more clear sooner as well. So this was their pivotal trial, which was with the AvaClear. This was with 104 patients, and this was the treatment protocol, which is what we do in the office. It's 3 treatments, 1 month apart. The important thing here is this was monotherapy, as trials usually are, but in real life, you're not going to do monotherapy. You're going to have them also on other things so they can get clear faster, or like what Dr. Carlson talked about, you might do some vascular lasers and all that as well, because you want to do kind of multiple things at once. And then their endpoints, they looked at responder rate of over 50% reduction in inflammatory lesions, secondary endpoint inflammatory lesion count, and then also nodule count reduction, and mostly moderate to severe acne. So broad ranges, and then most importantly, diverse Fitzpatrick skin types, which is always nice to see with lasers, because that's the number one thing you don't want to do. You don't want to hurt the epidermis or cause any pigmentary alteration, either hypo or hyperpigmentation. So safe in all skin types. And this is the IGA improvement at 3, 6, and 12 months. And this is kind of what I mentioned. At 3 months, you're done because you've done 3 treatments every month, but they'll continue to improve up to 12 months. So it's really important to have that discussion with patients. And patients did great. I mean, you can see the improvement over the year. And the importance is the sebaceous glands are gone. So it's similar. It's not head to head, of course, to isotretinoin, but it's a similar mechanism is the important thing to note. And this was also another one showing percent patients achieving more than 50% reduction in inflammatory lesions over 52 weeks. And you can see it really does take a full year to get to clearance. This is also very similar to that 52 weeks with the reduction in inflammatory skin. So I really do emphasize the 1 year thing to patients, just so they're not like 3 months, because teenagers will hear what they'll hear. And so side effects, pretty safe. The main thing we talked about, really your skin is left intact. That's the most important thing with the laser. There is some mild erythema. It goes away. A little bit of swelling right after. That actually all goes away pretty well. I would say as far as all the lasers we do, it's a pretty easy one to do. Patients do get some, not all, 42% get a little bit worsening of acne after the first one and some after the second one. That's not new to us because that happens with isotretinoin as well anytime you're messing around with the sebaceous gland. But very important to warn patients about, because if you haven't talked about that, that's going to be a problem. A little bit of dryness, a little bit of itching. But really, I think the main thing is talk about the 12 months, about a year for efficacy, and then also just talk about the flare-ups so they're prepared. And these are the results, and they're amazing. I mean, if you can get patients clear of acne, you're really changing their life. And like the amazing photos you showed too, Dr. Carlson. I mean, it's huge to take someone from getting up every morning and seeing that their face is covered to then clearance, but also clearance of the post-inflammatory erythema. I think it's really important not to leave patients midway. Thanks for joining us today on the Future of Dermatology podcast. If you enjoyed learning about the science behind skin, make sure to subscribe, and we'll see you next time. As a reminder, this podcast is for educational purposes only, not for medical advice. Always consult your healthcare provider.